welcome everybody, and it's so lovely to have so many of you here joining the IPSO Prader-Willi syndrome community, which is a very special one. So this is the first of our series, and we're starting where it all begins, with genetics. It's my great pleasure to introduce tonight Dr. Kate Baker. Kate's an honorary consultant in clinical genetics at Cambridge University Hospital's NHS Trust and program leader, track scientist with Medical Research Council Cognition and Brain Sciences Unit. She completed her clinical training in pediatrics and general genetics. Kate's research aims to fill the gap between genetic diagnosis and day-to-day problems for individuals with intellectual disabilities and their families. And Kate's now going to present to us on the genetics of Prader-Willi syndrome. Thanks, Kate.
Thank you so much for inviting me to participate in the event today. It's really inspiring to see a network of colleagues from across the world come together to learn together to improve care for people with PWS, and I'm excited to take part in that today. The material I'm going to present to you for the next sort of 15 minutes or so will be very familiar to many of you, if not most of you, based upon your introductions this morning. But that doesn't matter, because the important aim here is that we all have a shared basic understanding of the core clinical aspects of PWS and their genetic basis. And that having that shared basic understanding, I think, is essential so that this community can work together going forward, and that you can all fully access the future more detailed sessions and contribute to those. So that's the aim of having a short introductory session today. Check that I can, oh, my slides don't seem to be moving forward. There we go. So I'm going to be providing a very basic outline along those aims. I'm going to be providing you with three aspects of information. First of all, before we get to genetics per se, I'm going to be reviewing with you the clinical characteristics of PWS across the lifespan. I think that is very important, because some of you may work predominantly with adults, and having an understanding of the trajectory of their early life experience for patients and their families is important for recognizing a person with PWS and understanding their life history. Similarly, if you work with babies or young children, it's important to have a sense of what the future may hold. So that's the first part of the information. Then I will be providing some basic information about the genetics of PWS, and three, describing the diagnostic genetic testing pathway. All of this, as I said, will be very familiar to many of you. My core objectives are that everybody participating today will be in a better position to recognize a person who may have undiagnosed PWS. We know that there will be a large number of people in across the world, and some people in every country who have PWS that has not yet been diagnosed. And you may be the person to make that first recognition, or to empower your colleagues to be able to recognize that person with PWS. So that's the first objective, recognition. And the second is that you will have a full awareness of the diagnostic testing pathway, whether or not you're in a position to access it, or how easy it is for you to access it. So what is Prader-Willi syndrome, PWS? It's a lifelong multi-system condition affecting physical and mental health. It sits alongside many other developmental disorders. I think what is particularly interesting about PWS is that interaction between the physical and mental aspects of the condition. It's caused by loss of gene expression from the paternal copy of a region of chromosome 15 at location 15q11 to 13. I'll explain what that means later on. It's rare, occurring in around 1 in 10,000 to 1 in 30,000 live births. There are, of course, core shared characteristics, but every person is unique. There's no feature that is present in absolutely everybody or in the same way. And importantly, although there is no cure that can remove PWS, the physical and mental health outcomes for patients and for their families can be greatly improved by early diagnosis and optimal management. And those of you who have been working with PWS individuals for a long period of time know from your experience just how much difference can be made through best practice treatments, both physical health treatments, medications and therapies, and how the outcomes now are really very much better, or can be very much better than they were a couple of decades ago. So I'm going to run through now the characteristics of PWS across the lifespan. And as I mentioned before, a couple of reasons for doing that. One is that at any particular point in the lifespan, the characteristics of PWS can be quite non-specific. They could be caused by many different causal factors. It's really whether when you look at the life history and the progression of the condition that the pattern becomes more familiar and more obvious. So first of all, I'll review briefly how it can present in the prenatal era before birth, at the time of birth, and in the first few days and weeks of life. Before birth, individuals with PWS can have decreased fetal movements. They can have polyhydramnios or oligohydramnios, so too much or too little amniotic fluid. There may be, on ultrasound measurements, relatively large head to body size proportions, and sometimes comments about abnormal positioning of the hands or the feet. Individually, none of those features is going to be diagnostic, and even in combination, those are very non-specific potential signs of a future diagnosis. Sometimes couples will be offered some prenatal diagnosis, not for PWS specifically, but in view of these features. And if that is in the form of just chromosome analysis, that's likely to be reassuringly normal. At the time of birth, there's an increased rate of assisted delivery via forceps or one tooth or a cesarean section, and an increased rate of either prematurity or post-mature births, birth weight being typically low or low normal. So no strongly specific features around obstetric care itself. In the first few days or weeks of life, the characteristic features are predominantly hypotonia, so low resting muscle tone, poor suck leading to feeding difficulties, and a weak, quiet cry. Sometimes that can be, these features can be very obvious that there's a child here who's going to have some degree of difficulties, and the baby may be admitted to a special care baby unit, but not always. And families may take home a baby in the first couple of days of life with only very minor concerns that may emerge over time. Males can have underdevelopment of the external genitalia, and so can females, but again, very non-specific. So what is the classic picture of a young baby with Prader-Willi syndrome? So here is from a textbook, a picture of a baby who does have PWS. And I wanted actually to get everybody a bit busy today. If everyone wants to use the chat and just type all the features of this little baby picture here that you think might suggest to you that they have PWS. You take a minute to do that. Taking yourself back to the neonatal unit or to a baby clinic, if you were out in the community, anywhere in the world, what about this baby might make you think that they have PWS? Let me just see if I can see the chat. Oh, I can't. You can all read each other's evaluations. There we go. I'll give you a couple of moments. Feeding tubes, muscle weakness, posture, floppy, nasogastric tube, hands and feet, that's right. Okay. But they might be drowsy, yeah. Okay, I'll give you a couple more minutes. And then I'll tell you what I see. Okay, small hands and feet, yes. Face, hands and feet, face, yes. Okay, so I'll tell you what I would see first of all. So when I walk onto the neonatal unit, first thing I want to see is this a baby safe? So we do ABC. So this is a baby who's breathing spontaneously. They're not intubated with a tube. They're not requiring oxygen, and they're nice and pink. So they're not requiring intensive care. Having said that, there might be breathing concerns that they, I think, have an apnea monitor on. So perhaps there have been some concerns about their respiratory pattern. They've obviously had a lot of blood tests, which suggests that the doctors or the babies were, the doctors or parents were concerned that maybe this was a poorly baby. Maybe they thought this could have been a baby who might have had infection or low oxygen around the time of birth. but they've not currently got any lines in, they're not needing any fluids or any antibiotics. So they're generally a relatively healthy baby. Yes, they're having feeding difficulties, so they've got an NG tube in place. So they're sort of ABC, but they're pink and well perfused and warm. They're sleeping at the moment, but the key thing about the ABCD disability is the posture. So the frog-legged posture of low resting muscle tone. That is, doesn't mean they can't move, they're not paralyzed, but that they're very floppy, you can't support their own heads. The other things that I can see in terms of head size looks perhaps a little bit large for body size, and that in terms of facial features, perhaps, although I can't see very well, perhaps they've got quite small facial features for the size of their heads. What else can I see? But those are the main things. So a relatively well baby needing feeding support who's floppy. Oopsie daisy. It's forward. So do they definitely have PWS? Well, of course not, because there is a very, very broad set of potential causes for a baby who is floppy and having feeding difficulties. And the priority is going to be safe neonatal care and treating and testing for important preventable causes of future disability, like perinatal infection, like low blood sugar, like more significant inborn errors of metabolism, like endocrine difficulties. So there's going to be a very broad differential diagnosis. PWS is only going to be one of many things to consider. And a structure you might use is genetic or acquired, transient, stable, or progressive, and whether the hypotonia is originating from the central nervous system, the spinal cord, for example, spinal muscular atrophy or a lysosomal storage disorder, a neuromuscular problem or a muscle problem. And locally, you will have a local protocol for investigating very broadly. PWS, however, is usually part of first-line investigations in my centre for babies with quite significant and stable hypotonia, because clearly an early diagnosis is going to prevent many additional tests that a baby doesn't need if PWS is the cause. So we would do testing for PWS early in the first few days of life for a baby presenting with hypotonia. Do watch out for dual diagnosis, because it's perfectly possible for a baby with PWS also to have perinatal infection, which would need treating, also to have low blood sugar that needs treating. But however, if you treat for infection and the baby's hypotonia doesn't improve, then you should certainly be thinking about an underlying cause for that hypotonia, and PWS would be one thing to consider. I've put here as probably unnecessarily to communicate openly and cautiously with parents. So one's not going to look at this baby and tell some parents straight away that you think they definitely have PWS, because there are many different potential causes. But if you're testing for PWS, tell parents that that's what you're testing for, so that the result does not come as a surprise. So moving on past those first few weeks of life, and as I want to emphasize, many of you will have met families who received a diagnosis of PWS on the special care baby unit or via a health practitioner within the first few days and weeks of life. And they have grown up with their baby always having that diagnosis of PWS. But that's not the experience for all children and families in the developed world or in other countries as well. It may be recognized at a much later stage through life. So let's think about how it may present later in infancy, or be recognized later in infancy, or during early childhood or later childhood. So during the first, say, year of life, it's likely that feeding difficulties will continue, that the babies may experience gastroesophageal reflux, and sometimes babies will be treated for reflux with lots of changes in feeds and lots of hope that that their feeding difficulties and hypotonia are going to improve just with feeding support. And but however, weight will continue to be gained very slowly, and this will be a huge struggle for families during the first year of life, especially without a diagnosis. They may have developmental dysplasia of the hip, or some minor minor eye movement problems like squint or strabismus. And over the first year of life, a degree of developmental delay will emerge. That can be vary from mild delay in meeting motor milestones and sitting a couple of months late, or more a severe delay on not sitting and walking well into the second year of life. Let's highly variable and non-specific. So actually recognizing PWS in that first year of life is not going to be easy for health practitioners. During earlier childhood, so from the ages of 2 to 6 years approximately, some more characteristic and specific features tend to emerge, and that's the gradual increase in appetite and weight and a transition to hyperphagia. So hyperphagia, as you all know, meaning an increase in eating, and the characteristic sign of hyperphagia in PWS is that if food is available, then the individual with PWS will eat it, irrespective of how recently they ate or how much they ate recently. Alongside hyperphagia, there's emerging endocrine deficiencies, the growth hormone deficiency, the thyroid dysfunction, and the facial features may become more characteristic and more obviously different from other family members. And fingers, I'll show you a picture in a minute, that may become more obviously different from typical fingers over time. Febrile seizures are very common, affecting probably more than half of young children with PWS, and that pattern of variable degrees of developmental delay. Then during later childhood, really the similar difficulties continues with emerging obesity in the absence of food control, alongside sleep problems, sleep apnea, gastrointestinal problems, premature onset of premature onset of external features of puberty, and then that emerging pattern of learning difficulties ranging in severity from being really very mild to more severe, and then the emerging picture of behavioural difficulties that affect every person in different ways, sometimes with skin picking, sometimes with repetitive and obsessive behaviours and focused interests, and what I label as emotional storms. So sometimes anxiety, sometimes tearfulness, sometimes anger, affecting each person in different ways and managed differently in each family setting. So a couple of, are you okay there, Georgina?
Yeah, 10 minutes, Kate.
Oh, thanks so much. That's really helpful. Thank you. That's perfect. So in terms of recognizing the physical characteristics of PWS, I'm showing here on the left a composite image from the International Phase 2 Gene website, which I think you should all be able to access, which merges together photographs from around 100 individuals with a diagnosis of PWS during childhood to create what's called a gestalt, the average PWS face. Here, interestingly, or on a Caucasian background, which I think certainly skews your perspective of how easy or difficult it would be to recognize the facial features, depending upon your ethnic context. But as you can see, the sort of almond-shaped eyes, slightly broad nasal tip, thin upper lips, smooth philtrum, slightly flat mid-face, but very, very soft signs that will be much harder to recognize in some individuals than others. And here on the right is an older photograph of two people's hands with PWS, where you can see the tapering shape of the fingers with thinner tips of the fingers and somewhat broad knuckles with a slightly doughy or loose skin appearance over the knuckles. Sometimes it can be very obvious and oftentimes not at all. So thinking again in the similar way to thinking about the flocky baby, when you meet lots of people with PWS, you might think, well, surely it's obvious, it would be easy to detect that somebody presenting with developmental delay and obesity would have PWS, but no, there are many different causes of being overweight during childhood with developmental delay, and it's important to retain that broad perspective, partly because families may have been given many different potential diagnoses before finally being tested for PWS. So the first and largest group will be social environmental causes. So poor diet, poor access to healthy food, perhaps medication that's increasing weight, lower levels of physical exercise or access to sport during childhood, and familial causes of being overweight. Those are going to be by far and away the most frequent causes of being overweight, and having developmental delay or learning difficulties are probably going to exacerbate risk factors for being overweight during childhood. Then there are going to be endocrine causes, hypothyroidism, growth hormone deficiency, Cushing syndrome, isolated or as part of a wider syndrome. PWS is probably the #1 genetic syndrome that most doctors would think of as being associated with these features, but there are others, obviously Fragile X syndrome, Prader-Willi syndrome and other ciliopathies, Cohen syndrome, and increasingly over the last 10 years, there's been a huge push toward identifying new single gene causes of obesity and developmental delay. And if you're in a country with access to gene panels or to exome sequencing, there's an increasingly large catalogue of potential diagnoses that may be made. Finally, let's think about PWS across the lifespan in later life. So it's a lifelong syndrome and the problems don't go away. And as we all know, adolescence is a challenge for everybody. And many of you support young people with PWS through into adulthood, during which a major area of constant requirement for management is dietary control, as individuals move from being dependent on their families to being semi-independent. And then alongside dietary control, management of the secondary consequences of obesity, if it hasn't been well controlled, alongside managing puberty, which can be delayed, and then physical features like scoliosis, emerging intellectual disability, and a lot of challenges with managing social interactions and relationships. Depression and anxiety is very, very common. And may be transient or may become a more persistent and difficult to treat aspect of the syndrome. And those challenges continue into early adulthood with the transitions to supported independence, management of diet and physical health, minimizing secondary health consequences, and treatment of mental health problems and symptoms, which can include psychosis in some individuals. And those problems don't go away in later adulthood. With increasing life expectancy, the care of the older adult with PWS is, I'm sure, going to be very important. Many of you know all of this. It's very familiar to you, but I think it's important to remember that across the world, the majority of adults with intellectual disabilities do not have a causal diagnosis still and have never had access to genetic testing. So there's still a major need to recognise adults who may have PWS or other conditions and open up the opportunity to obtain a diagnosis during adulthood. That will be significantly important for their health during later life.